Hi guys, Dr. Patil here and I welcome you to the prep ladder NEET assess video modules. In this video module, we will be taking a quick overview of bronchiectasis. Now there are various causes for bronchiectasis and there are various characteristics of bronchiectasis under those headings we need to remember, but that will be dealt separately in those individual video modules. Okay, now let us begin by defining bronchiectasis. How do you define bronchiectasis? Bronchiectasis is defined as abnormal and irreversible. Both words are equally important. Abnormal, irreversible dilatation of bronchi. Okay. Does that mean only bronchi are involved in the pathology of bronchiectasis? The answer is no. This pathology is often associated with obliterative bronchiolitis. So bronchioles are also usually affected. Obliterative bronchiolitis. Okay. Now, if you have a patient with bronchiectasis, are you expecting him to fit into the PFT picture of obstructive lung disease or the PFT picture of restrictive lung disease? Largely speaking, bronchiectasis is an obstructive lung disease. So obviously, I would be expecting the obstructive PFT. It's an obstructive lung disease. So when I do PFT, on the PFT, I am expecting the FEV1 to be reduced. And as you all know, FEV1 by FVC ratio will be reduced. It will be less than 70%, or if you want to express in decimals, less than 0.7. Okay, but you have to also remember that in certain forms of bronchiectasis, there may be an element of restrictive lung disease involved. The typical example I can quote is the UIP type of interstitial lung disease. So in UIP type of interstitial lung disease, it's a very aggressive form of fibrosis, right? Where fibrotic process sometimes twists and turns the bronchial tree in such a way that it can lead to development of what is called as traction bronchiectasis, right? We call it as traction bronchiectasis. Now, this traction bronchiectasis might contribute to some degree of obstruction, but predominantly this patient's PFT is going to resemble like the restrictive lung disease because the primary pathology is an interstitial lung disease. Okay, so that's the basic understanding of bronchiectasis. We have an obstructive lung disease characterized by abnormal and irreversible dilatation of bronchi with obliterative bronchiolitis. Now, morphologically, bronchiectasis is classified into three variants. Okay, number one is known as cylindrical, and this can also be called as tubular bronchiectasis. Tubular bronchiectasis. Okay, number two is called as varicose bronchiectasis, and number three is cystic. In terms of severity, cystic is the most severe, and among the spectrum, relatively less severe is your tubular. It is less severe, and your varicose sits somewhere in between. Okay, now what is the difference between the normal bronchial tree and when do you say that the patient has cylindrical bronchiectasis? One thing is very clear that in case of bronchiectasis, the bronchi are dilated, abnormally dilated, and the bronchial wall is characterized by thickening. Okay, but when you look at the image of a normal bronchial tree, what you see is as there is branching of the bronchial tree, the subsequent branches, there is tapering. Like you can look at this image, as you see the branching, it keeps on tapering. It is not like a parallel railroad track, right? It keeps narrowing down. But in case of the cylindrical bronchiectasis, these dilated bronchi are maintaining the parallelcy. Can you notice that? It is like all parallel. It is not tapering down like this, right? It is not tapering down. It is maintaining parallel. That's why it is called as tubular. It is like a tube or it is like a cylinder. That's why it is also called as cylindrical. In case of varicose bronchiectasis, there is varicosity like dilatation and constriction. Like you can see in this image, there are abnormal segments of dilatation at multiple levels, and in between that there are zones of normal or constricted airway. That's why it's called as varicose. And in case of cystic, as the name says, there is cyst-like or a grape bunch-like collection of dilated bronchi, right? So you can see that it is like cysts. That's what is called as cystic bronchiectasis. Clear? Okay. Now, in terms of the causes for bronchiectasis, we can divide them into acquired and congenital. Okay. You have to also remember that congenital causes of bronchiectasis are generally associated with diffuse or more aggressive and more extensive involvement of the lung in comparison to acquired. Acquired are generally focal. Okay. Why is it focal? I'll come back to that in a bit. In case of congenital, the first cause you need to remember is cystic fibrosis. It is cystic fibrosis. Definitely, I have dealt with cystic fibrosis in a separate video, and I'll be coming out with another video where we will be getting an update on the management of cystic fibrosis. For now, just remember, congenital causes, the first cause that comes to your mind is cystic fibrosis. Apart from that, there are various inherited conditions that one need to know, starting with what is called as Munier-Kun syndrome. Munier-Kun syndrome. Okay, what is Munier-Kun syndrome? This is a congenital condition where there is tracheobronchomegaly. There is tracheobronchomegaly or tracheobronchomalacia leading to tracheobronchomegaly. Now, this actually leads to increased risk of recurrent infections, and these recurrent infections are indeed responsible for patient developing the bronchiectasis. That's what we call as Munier-Kun syndrome. Okay. Now, the other condition I want you to remember is what is known as William-Campbell syndrome. William-Campbell syndrome. So this condition in itself is defined by presence of bronchiectasis. William-Campbell syndrome. Now, what is the abnormality here? In William-Campbell syndrome, there is destruction of the cartilage of the airway. Destruction of poor development of the cartilage, and because of that, patients develop bronchiectasis. Okay, so we call that as William-Campbell syndrome. Okay, other than that, we also have conditions like primary ciliary dyskinesia with situs inversus. Then we have Young syndrome. That's the fifth condition I want you to remember. Young syndrome, and also your yellow nail syndrome. I think if you remember these six, that's kind of adequate for writing your university paper. Yellow nail syndrome. So these are the conditions which are associated with congenital forms of bronchiectasis. Now, what are the acquired causes for bronchiectasis? Acquired causes, number one you have to talk about is post-infectious. After some segment of the lung gets infected, after that it can lead to destruction of the cartilage as well as the smooth muscles of the airway, and then it can lead to development of the bronchiectasis. So post-infectious, when I talk about, most importantly from the perspective of India, you need to remember tuberculosis. Tuberculosis is the most important cause for post-infectious bronchiectasis. And obviously when we are talking about post-infectious bronchiectasis, it's most likely to be focal. Some site of the lung is affected. Like when we talk about tuberculosis, obviously I'm talking about right upper lobe, or generally speaking we're talking about upper lobe. In patients who had recurrent aspiration pneumonia and developed anaerobic infections, in that case it is again going to be focal, and it is most likely to be right lower lobe, right? So generally infection means it is focal. That's why I said acquired, infection being the most common cause, it's most likely to be focal. But in case of most of these congenital, it is diffuse, more extensive involvement of the lung. Okay. Now, number two cause for the acquired you need to remember is allergic bronchopulmonary aspergillosis. So in the recently concluded video, we have discussed about the allergic bronchopulmonary aspergillosis, one of the upcoming topic for MCQs. Do read about that. Now here, remember, allergic bronchopulmonary aspergillosis is another acquired cause for bronchiectasis. And as I've already told you in the main video also, ABPA is also going to be focal, not diffuse, mainly involving proximal or central airways more than the peripheral airways, and mostly affecting the upper lobes more than the middle or lower lobes. That's typical story of allergic bronchopulmonary aspergillosis. Okay. Other than that, you can also have development of bronchiectasis in patients with alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. So you might have development of bronchiectasis there. That's a third condition that you need to remember. As I've already told you, you will also be thinking about recurrent aspirations as recurrent aspiration or aspiration pneumonia as a cause for bronchiectasis. These are acquired. Most of these cases are likely to be focal, and congenital, as I've already told you, are likely to be diffuse. Okay. So these are the causes for your bronchiectasis. Now, in terms of the pathophysiology, what is the abnormality that is happening? So when you take a section of the bronchi of these dilated segments, what you will notice is, number one, when you look at the lumen of these dilated bronchi, they are loaded with mucus. So there is increased mucus production. So it may be associated with hyperplasia of the mucus producing glands. Okay. Number two, you will notice is there is destruction of two important components. One is smooth muscles. Smooth muscles are destroyed. Smooth muscles of the airway are destroyed. Number two is destruction of the cartilage or elastic tissue. destruction of the cartilage or elastic tissue and smooth muscles. And this is what exactly makes it irreversible. Once the cartilage is destroyed, regeneration of cartilage is less likely to occur. Once smooth muscles are destroyed, probably less likely to regenerate. That's exactly why you develop irreversibility. Right. Okay. So that's the basic change that you will see on the histopathological examination. So in terms of pathophysiology, once this destruction occurs, whatever may be the cause, post-infectious or congenital inherited causes, whatever may be the cause, it also leads to stasis. So whatever extra mucus that is being produced, right, that leads to stasis. There is one more important reason for stasis, which I forgot to mention. The third change you notice, not easy on routine histopath, but when you are able to do a electron microscopic examination, you will see that there is loss of cilia. Cilia are lost. So the loss of cilia also contributes to poor clearance of the mucus from the airway. So that leads to stasis of the mucus. Now, whenever there is stasis, the infection risk obviously going to increase. So there is increased risk of recurrent infections. Now, these infections will indeed contribute to the destruction of the smooth muscles and the cartilage. So patient is now stuck in a vicious cycle. Right. For example, if I take the example of pulmonary tuberculosis did occur. The PTB was responsible for destruction of smooth muscles and cartilage, but now the dilated bronchi is becoming a site of infection, and the infection is causing further destruction of the smooth muscles and cartilage. So patient is now in a vicious cycle, and that's exactly why again reversibility becomes impossible in patients with bronchiectasis. Okay, so that's the basic pathophysiology. Okay, now coming to the diagnosis, how you diagnose a case of bronchiectasis? Number one, obviously, these patients clinically present with, clinical features wise, these patients present with chronic cough. Chronic here means obviously more than 8 weeks in terms of duration. Chronic cough with copious mucus production. Now, often you have to remember that it is not a stable case. Most of these patients have frequent exacerbations. Frequent exacerbations when this mucus becomes mucopurulent. Exacerbations are mostly because of infections, so this mucus production becomes mucopurulent. So that's the usual story. Someone having long-standing cough, presenting with frequent exacerbation. Otherwise, there is increased amount of mucus production, but during exacerbation, it becomes mucopurulent, right? Okay. Now, when you see such a patient, you start with evaluation using a chest X-ray. You might have done the PFT where you would have already got an obstructive picture, but you do a chest X-ray. You might have evidence of bronchiectasis, but the better investigation would be doing the HRCT, because the CT will help you precisely locating the segments of the lungs where the bronchiectatic changes are present. So on the HRCT, you will be able to see those dilated abnormal bronchi, right? Now, this dilation, particularly in case of the tubular bronchiectasis, leads to presentation in the form of two important signs. One is called as tram track sign. You know the trams, right? The ones that are running in Kolkata. Tram track sign. So they're track. And the second one is known as ring sign or signet ring sign. You can call it as ring sign or signet ring sign. These are better appreciated on a HRCT rather than on your chest X-ray. These are particularly about a patient having tubular bronchiectasis. In other cases, anyway, you will see the varicose nature of the bronchiectasis, or you will be able to see the cystic nature of the bronchiectasis. Now, what additional information HRCT will tell you is, in case of the bronchiectasis, whether it will tell whether it is diffuse versus focal, and if it is focal, whether it is affecting upper lobes more or lower lobes more, and it will also tell whether it is proximal more or distal more. Right? Distal means towards the periphery of the lungs, proximal means towards the hilum of the chest, right? So if the bronchiectasis is more towards the hilum, you can say it is central or proximal bronchiectasis, and when it is towards the periphery, towards the pleura, you can say it is peripheral. Now that definitely gives some clues towards the diagnosis. Okay, like for example, we were talking about the allergic bronchopulmonary aspergillosis or alpha-1 antitrypsin deficiency. In these cases, it is usually central towards the hilum. Okay, so that's the HRCT. Now HRCT might hold additional clue. For example, look at this image. Now what is this image? This is image of a patient who is having cystic bronchiectasis. You can see all this cystic dilatation, more extensive and severe, and you can see that the bronchiectatic changes are spreading out towards the periphery. Or in other words, I can say this is more diffuse. This is more diffuse. This is not focal, right? When I say diffuse, I would be mostly expecting congenital causes more than acquired. This is actually HRCT of a patient who has William Campbell syndrome. William Campbell syndrome, in which there is destruction of the cartilage of the airway leading to this cystic dilatation. And once there is cystic dilatation, obviously recurrent infections and further complications do ensue. Okay, let me show you one more, the HRCT, right? Look at this HRCT. In this HRCT, I'm sure you're already looking at the cystic dilatation of the bronchi up, and you're also noticing that it is more diffuse and more extensive, spreading out from proximal to peripheral. So it is more diffuse. I think you agree on that. Okay. Apart from that, if you notice the tracheal tree, you will notice that it is quite dilated, right? The tracheal tree is dilated. So this dilation of the tracheal tree is because of the congenital tracheobronchomalacia, right? So which syndrome we spoke about when we spoke about congenital tracheobronchomalacia, right? We spoke about what is known as Mounier-Kuhn syndrome. So this is a HRCT of a patient with Mounier-Kuhn syndrome. It again more diffuse, as I've already told you, congenital. Okay. Now we are going to see one more HRCT. In this HRCT, this is very typical. So the two HRCT we have seen were cystic bronchiectasis. Now this is a typical HRCT of a patient with tubular or cylindrical bronchiectasis. Okay. So look at the image. In this image, you probably can appreciate a parallel dilatation, right? The bronchial tree, as it is dividing, it is not getting narrowed down. There is a parallel dilatation. So as the bronchial tree progresses, it should keep becoming narrower, but we are not seeing that. They are all running parallel lines. I can draw multiple of these parallel lines, right? Can you make a note of that? Exactly, multiple parallel lines. So this is looking like a cylinder or a tube, and that's why we call it as tubular. And if you look at this image, the bronchiectasis is more focal. I can say it's more towards the hilum. Yeah, I do see that there is some peripheral bronchiectasis, but it is relatively predominantly affecting the proximal or central. Okay, so this sign of dilated bronchial tree looking like two railroads is what is exactly called as tram track sign. Some books do address this as railroad sign. That's perfectly fine. That's same, railroad sign or tram track sign. Now in the image, you will also notice that when you catch these dilated bronchi end on, instead of seeing them along their axis, when you slice through that, when the HRCT slices through that, you will see such images, right? Now this is what is known as signet ring sign or ring sign. Signet ring sign or ring sign. Why is it called a signet ring sign? When you look at an adjacent blood vessel, you can probably, the resolution is poor, but you can probably appreciate it here. So this is your dilated bronchi, and what you see here is a blood vessel. So when you look at an adjacent or an accompanying blood vessel, when the diameter of the bronchi is more than 1.5 times the diameter of the adjacent blood vessel, it looks like a diamond ring. Right? When it is present, we say the signet ring sign is positive, and it looks like a diamond ring. So some books also calling this signet ring sign, they also call it as diamond ring sign. Diamond ring sign. Both of these are signs of tubular bronchiectasis specifically. Okay. Apart from that, you might also have some large airways in patients with bronchiectasis, which are loaded with mucus that might give rise to what is known as finger in glove sign, more typically described in patients with allergic bronchopulmonary aspergillosis, which I have already discussed in that video. Right? So this is how we approach the diagnosis. Imaging is the mainstay of diagnosis. Obviously, you will be looking for presence of other clinical features, and you will also be looking at the nature of the bronchiectasis and its distribution. That might give you a clue towards the diagnosis. Now, once you have diagnosed these patients, how do you treat? What are these patients' problems? Problem number was chronic cough with increased sputum or mucus production. Number 2 is recurrent infections. And number 3 problems These dilated bronchi, I forgot to tell you, might also present with hemoptysis. Sometimes there may be bleeding, not massive usually. Submassive hemoptysis is a problem, right? So how can we help these patients? Airway are anyway irreversibly dilated. So when you have to talk about helping these patients, you have to only address their symptoms and you can try to treat the underlying cause. Now, how can you help with their chronic cough with increased mucus production? Can you give them cough suppressants? The answer is no, you cannot give cough suppressants. The simplest reason is that will make more mucus accumulation in the airway. So you have to facilitate mucus clearance. Now, how can you facilitate mucus clearance? You can do that by two things. Number one, you can give them mucolytics, which is indicated for all patients, like your N-acetylcysteine, which is what I usually prescribe, mucolytics. And number two, that's most important. More important than the prescription of mucolytics is chest physiotherapy. And when you say chest physiotherapy, physiotherapist will mostly be dealing with something known as postural drainage. Postural drainage. So trying to put the patient in a postural position that facilitates draining out of this mucus. That's very, very important, and that does make a difference to the patient's outcome. Okay, that's all you can do for the chronic cough. With respect to respiratory infections, hygiene is definitely going to be important. Okay, apart from that, patients might require prophylactic antibiotics in selected set of individuals. Okay, and you should also understand which bacteria are particularly known to cause infections. For example, Pseudomonas is very commonly colonizing bronchiectatic segments. Pseudomonas is one organism that you need to remember. Then other gram positives like staph can be one of the reasons. Staph or strepto can be the reasons. And you have to also remember the Burkhold area, Cenocepacia, particularly in patients with cystic fibrosis, is an important reason for recurrent exacerbations and sometimes catastrophic infections. And of late, because of frequent hospital visits, Acinetobacter baumannii is also becoming a problem. Acinetobacter baumannii. So you need to keep these organisms in mind when these patients present with exacerbation, and if at all it calls for prophylactic antibiotics, probably you need to keep in mind that you need to address all these organisms, most importantly Pseudomonas. So the usual practice is to give them inhaled aminoglycosides as one of the prophylactic antibiotic, or you can consider giving them azithromycin in selected set of individuals, but obviously there is concern about rising resistance against azithromycin, so not routinely practiced anymore. And prompt identification of infection and institution of treatment when you have infection is very, very important, because every episode of infection leaves behind much more destroyed airway, much more poor PFT parameters. Okay, in terms of hemoptysis, most cases are relatively mild, self-limiting, so just trying to treat the exacerbating features and underlying disease is more than adequate. But if it is catastrophic bleed, maybe you need to take the appropriate steps, right? So that's how we deal with bronchiectasis. This is a very quick overview. Individual conditions I will discuss individually. Thank you all.